The views and opinions of our guests are personal and do not represent their institutions or Applied Prevention Science International.
Okay, why don't we start? Hi, everybody. I'm Celie Sloboda. Good morning. I'm Celie Sloboda. Welcome, everybody, to APSI's Prevention Talks. Today, we are very pleased to introduce Dr. Hendricks Brown to our Prevention Talk series. As you know, these talks have highlighted a broad spectrum of prevention issues. We've discussed the culture of prevention, what has to be achieved in order to support public health prevention efforts. Dr. Doug Coatsworth from the University of Tennessee, Knoxville Center for Behavioral Health discussed how to address the stresses of COVID in parenting. Rebecca Hirsch from George Mason talked about stress in the workplace. Then we had Dr. Peter Wyman and his team from the University of Rochester School of Medicine talked about the prevention of suicide. In May, Dr. Daniel Flannery and his team talked about the violence prevention. And in June, Bill Crano from Claremont Graduate University gave us a guide to developing effective media-based prevention messaging. And then we had a month off vacation. Today, Dr. Brown is presenting. I have known Dr. Brown for a long time, and I consider him one of our prevention Jedi who accelerated the recognition of the science that was the foundation of evidence-based prevention programming that we have today. In the 1980s, researchers who were developing and evaluating substance use prevention programs were really held to extremely challenging demands at the time. And it was our research methodologists led by individuals like Dr. Brown that helped the field not only meet these demands, those challenges that we had, but to go beyond by providing the tools that were really necessary to determine how these interventions impacted participants' behaviors, and also to examine the processes that were involved that led to the desired outcomes that we were looking for. So today, Dr. Brown and his colleagues support the Prevention Science and Methodology Group of Northwestern University that provide monthly webinars on current topics of interest, not only to prevention researchers, but also to practitioners. I'm going to turn this over now to Susan, our colleague. Susan.
Thank you, Zoe. I'm pleased to add my thanks to Dr. Brown for joining us today, because a lot of the work that we're all doing is trying to figure out how to get out there the methods that we've learned that can actually work in prevention. He has been exploring these effective methods for a long time, and he's going to talk today about some of the challenges that remain. We've heard for years the term scaling up, which what we always thought of as applying the knowledge and skills from research to the community and doing it sort of singularly. That's what the job is. But here we're going to talk about something called scaling out, and some of us have used that the expression of platforms, looking for existing platforms in the community where we can capture the concepts learned in research and putting them into practice. It's a lot harder than we think. And Dr. Brown is going to tell us about some of those challenges, and but also how we people in practice can apply that knowledge. But first, a couple of housekeeping issues. By the way, please mute. We have many people online right now, so muting is really will help us communicate better. The other thing is we're recording, as you probably saw the notice, so that people who aren't able to join us today can watch later, along with all the other prevention talks Zoe mentioned. They were all recorded and are available for viewing. The other issue is that any questions, I mean, this is meant to be a two-way street. We want to hear from you about any questions. And to do that efficiently, please put them into the chat. And we'll do our best to answer now and put those online to our speaker. And we'll hope to follow up with those that we can't reach during this session. Well, I think that's about it. And I will turn it over to Hendricks now. And thanks again, Hendricks, for joining us today.
Thank you, Susan and Zilly, for this great opportunity to talk. That really, really nice introduction.
Webinar.
Let's see. I wanted to return the favor. I'm going to talk a little bit at the very end and invite people to join the Prevention Science and Methodology group that so you can hear other experts in the field. Zilly did a presentation a little while ago in that, and so we'll give you some more information on this one. This work, as Susan said in here, is about scaling out. And I just wanted to give a quick comment about where we are going in this field. We have to learn from each other. We can't afford to wait. This is an international effort due to Zilly and to a number of other people, Susan, the organization that you folks have, to learn from each other. It's not a one-way street. It's trying to collaborate and learn how ways to move the prevention efforts forward across a set of diverse outcomes that we all need in different places. But as we do that, there are unique factors in here that need to be translated into the settings where they are going to be delivered. So years ago, I had an opportunity to consult in the Netherlands with the ZON organization, Z-O-N, and about their prevention programs. And they actually piggybacked on a lot of the programs that were done in the United States, and they moved faster than we were able to in the United States. We look for opportunities like that all the time, but we don't make as much use of it as we could. So the scaling out is related to this kind of effort in here. But to acknowledge the funding in here, NIDA is for the last 10 years, the Center for Prevention Implementation Methodology for Drug Abuse and HIV. Even though this is focused around drug abuse and HIV, I'm going to give the example in here about HIV. It's a methodology center. It should be crossing a lot of other different outcomes that you folks have been interested in as well. It's also connected with the Third Coast Center for AIDS Research as well. And we have a group called Bridges, which is a link between service delivery and research that you can go to if you'd like to. So here's one of the basic issues in here. We're not investing sufficiently in the knowledge needed to deliver evidence-based prevention programs to scale. I'm going to talk a little bit about HIV prevention and particularly an intervention, a medication called PrEP, pre-exposure prophylaxis in here. And I'm going to talk a little bit about the United States experience in here with Latino disparities in HIV prevention and treatment. So PrEP is for those people who are at risk for HIV prevention, but do not have HIV negatives in here. If it's taken effectively, essentially it's a medication that is dosed every day. It's at least 90% effective in reducing HIV infections. CDC has a set of clinical guidelines in this one. The latest in here is listed at the bottom in here, about 2017. Hasn't been updated fully from that time, but what it could do is it could substantially reduce HIV infections in here among those who are sexually active adult men who have sex with men. About 1 in 4 of those MSM could be suitable for using PrEP on a routine basis in here. It's also for adult heterosexuality, sexually active men and women in here. particularly those in serodiscordant couples, also with injecting drug users as well. 1 in 5 could probably be using this one. It's important to note that not everybody, there's not enough data around every single group in here. For example, among adolescents, the data on safety and efficacy is still insufficient to really give CDC guidelines on this one, but I think it's an important group in here. We need to try and take into account those at highest risk. So about 10% of the people in the United States who are eligible are taking PrEP. Most of the people who are most at risk, young African American and Latino MSM, are the least likely to take PrEP routinely. So that's a group that we think, even though there's not as much data already from efficacy and effectiveness studies, it's still worthwhile doing in here for many kinds of situations. So it's not enough just to have an evidence-based intervention. It's the delivery system that matters. This is a statement that we've been using in here to emphasize the role of implementation. And you can read it yourself in here. If this is not clear, just take a look at the COVID-19 vaccines. It's not enough just to have them. It needs to really be distributed to those who need them. And without that, you don't have any availability of using those as prevention. This is what has been called the traditional translational pipeline. It's originated from NIDA back in the days when Zilli was in charge of the division, DESPER at NIDA, and has continued since that time in here. And I think it uses an important dimension about how we build on the sets of studies that are done. Pre-intervention studies to be done initially in here to identify potential interventions that might work. Efficacy studies are really emphasizing, could a program work under ideal conditions? If you move up the ladder in here to effectiveness studies, does a program work in real life settings, in schools, for example, or in other organizations? And at the same time, researchers are providing a number of technical supports for trying to deliver that program. The third stage in here is implementation research, and it's also connected to implementation practice. It's the big yellow box in here. And that's much more of an engineering point of making a program work under the settings where you're not only adopting these interventions and getting organizations and communities to use them, but also all the way through sustaining those programs over time. But here's what the NIH world looks like over here for HIV programs. It looks like the emphasis is in here is on the earlier stages. Could a program work? And some does a program work? And the group that's making a program work, that is implementation, there's only about 4% of all of the HIV studies in the last 5 years that are related to implementation science, having aims related to implementation science. And only half of those had an implementation measure identified. So we really have an absence of knowledge in here about what we need to do to make things work. So this is about why we're talking today about scaling out. Just to give you a couple slides about what the implementation world looks like in here. Well, let me start with this one first. These are also follow-up of the study populations that have been used for implementing HIV prevention and treatment. And here you can see Latinos down here is one with only about 2 or 3% of the populations of the studies that have been emphasizing Latino populations. That's important because the HIV disparities and the prevalence of HIV, Latinos have about 2.5 times the risk of non-Latino whites in the United States. And if you look across the 775 counties in the United States, about 95% of those have HIV disparities that place bigger burdens on Latinos than non-Latinos. Here's the Latino population in the United States is about 17%, so we have a huge disparity in here. We've called this a scientific equity disparity in here, or inequity associated with the scientific side. So not just health disparities is an issue in here, but also issues of scientific inequities in terms of the amount of knowledge that we have for people to be able to use this. And so here's a couple references that we've had. Implementation research has a bit of a different emphasis than effectiveness studies. So on the left-hand side, we're going to talk about what an effectiveness study is intending to do versus the implementation study. So on the effectiveness study, the concentration's on the intervention. And we want to know whether or not that intervention is going to work. We have a system of support and adoption and delivery of that with fidelity. That's in the background. We don't get paid in the grant proposals to really investigate that in effectiveness studies. We really look at, does an effective study work, and we evaluate their health outcomes. On the right-hand side, part of the thing in the implementation is really to understand the system that supports the adoption, delivery, and sustainment of those in the same intervention. And in background in here is the evidence-based intervention that we're talking about. We're looking at evaluating the quality, quantity, speed of delivery, how many people are served, what the reach is, for example. And it carries over into what we measure, what we model, what we test or evaluate. That's all the things about implementation. You can do very rigorous randomized trials in implementation science. Here's one that we conducted a couple of years ago, more than a decade ago, which we call a head-to-head randomized implementation trial. It's looking at two different implementation strategies, but both of those are delivering the same evidence-based intervention, which was treatment foster care. One of those was called a community development team. It's a learning collaborative where communities, those are counties, get together, 6 or 8 at a time, and work together to collaborate on how they can best deliver those programs. How can they pay for that? How can they recruit individuals to deliver the program as they need to? How can they provide ongoing support and the like? The standard setting in here is the other comparison in here, and that's same intervention, the same implementation, but it's delivered county by county rather than as a group of community of counties working together in a learning collaborative. And then we compare how fast, how well, and how much is delivered. So this is what it looks like in the design that we did. This is a randomized trial. It randomizes two things in here. It randomizes counties, and there are 51 counties in California and Ohio, so two states in the United States, to which implementation strategy, that is the community development team or the standard setting. And then it also randomizes the time at which these counties are brought in to do the study. So if you look at the first 40 counties in California, there are actually more than 40 counties in California, but we removed the ones that had already had exposure to this particular intervention before. So these are new counties, and they were divided in cohort 1 into 3 groups, one that got community development team, another one that got the standard setting, and then a third was waitlisted until the next cohorts, and those got divided up into the community development team, standard setting, or waitlisted, and finally the Ohio counties were the last group in here. So that was a design that we used and evaluated that study and found that the learning collaborative did have some benefits in terms of a larger number of individuals that were served with that. So I'm going to shift to what we mean by scaling up and scaling out of an evidence-based intervention. So I'm going to start off with the term, as Susan said, the more common term that people use is scaling up. The idea is this: if we deliver an evidence-based program to the similar population and a similar delivery system, it seems reasonable to expect that we would get similar results that were found when we did this to establish the evidence. That makes a logical sense and is sort of the basis of what we be doing in here, but it's not without a few provisos in here. So you need to have good fidelity of the evidence-based intervention. Sometimes that comes along pretty easily because if it's a pill, there's standards in terms of the quality of that. If it's a behavioral intervention, that's an important piece to try and deal with. It's also the fidelity of how the evidence-based intervention is delivered. So that may require a substantial amount of supervision, for example, training and supervision, and those are going to be important to be able to have in here. And also it has to have acceptance not only by the population, but also the staff of individuals who are delivering those programs. So I'll talk about scaling out as opposed to scaling up right now. And this is a paper that Greg Ahrens and a number of us worked together and published a couple of years ago in here. And there are three types of scaling out that we identified in here. So type 1 is the population is the same as what it was previously when an evidence-based intervention was delivered, but that there's a different delivery system. So, for example, PrEP might be used to deliver to men who have sex with men through public health clinics. That might be one place where it was at one point relatively rare for public health clinics to be delivering PrEP. There are some requirements in here that a physician needs to be involved in terms of making sure that there's no problems with kidney failures that are going on and monitoring that. And so there are some requirements in here for delivery of PrEP. The second one is the delivery of the system is fixed, but there's a different population. So this might be looking at adolescent MSM through HIV clinics, which would be the standard place for the delivery of those programs. And then I'm going to switch to the third group in here and talk a little bit more detail about one that has different populations and different delivery systems at the same time. So we're talking about the ones who in the United States probably need it most, and those are young African-American MSM. And then delivering it from home visitations or other places in here, because most of those young African-American MSM are not connected to clinics. So we have to go out and find ways to deliver those, and then we'll talk about what people call on-demand dosing as a different kind of model for that. So again, here's what this traditional translational pipeline looks like. It's a lot of work in here. It's part of the reason why it takes 14 years or so for an evidence-based intervention to come to be used in here. If we do this in one context, it may take us 14 years or so. And in fact, with PrEP, you can go back and find it really did take that amount of time for delivering PrEP. But if you do it in another context, you may need to go through the entire process again. Another context, another process again. Well, that's another 2 times 14 years of work over here to try to put that all together. It just seems inefficient and ineffective in terms of way to do this one. So what we're talking about is the kind of things that we use so that by the time you get to the second context, you can use a lot of the information and borrow strength from previous studies in here. And then the third context in here that you might need to can use information that's available as well. So that's the theme and the idea behind this one, to borrow strength across these. And so you don't have to go through this big, huge effort in here, and only use and pick and choose parts of the model that make sense in here. We do need ideas about why an intervention would work and how it is delivered. We call that a conceptual theory of mediation. We do have to have at least some part of that knowledge base around a mediational model, a causal model of how a program works in order for scaling out to a different population or a different delivery system or the combination of those two. And we built around Tom Cook's principles for generalizing causal inference in here. I'm just going to talk about really briefly two of these: principle of proximal similarity and heterogeneous irrelevancies in here, but there's others that are available in here. And then the part that is going to be relevant to what we do in terms of working in real life research studies in here is to look at the levels of evidence that would be required for us as we move to this new research location in here. I'll talk about 4 levels of evidence. Minimal or no empirical evidence is needed. Second is that you can use some proxy measures to do some empirical evidence in here. Direct empirical evidence or full randomized hybrid trial. Hybrid trials are ones that include efficacy and effectiveness at the same time in terms of their aims. Now, I mentioned issues. This may be familiar to many of you about using re-aim. These are 5 elements of how do you look at the effectiveness of intervention as it's delivered to a population. It works for both prevention and treatment. You need to have portion of the eligible population has to be high. That's generally called reach. Effectiveness of the intervention, strength of impact. Adoption, how many different sites start delivering it. Implementation, that is, can you deliver the intervention effectively? And then maintenance, or another word is to sustain these practices over time. So those are 5 basic elements, and essentially the population impact is approximately the product of each of those. So if you only reach half of the population, have half of the effectiveness, half adopt, half implement, and half get maintenance, the product of those, I think, is about 6% or so. So you can see that you can have a very low impact even if you have a good evidence-based intervention to start with. So this is a large table around the rows of these things correspond to the 4 dimensions we had of level of evidence that we would want to have: minimal or no evidence, proxy evidence, direct evidence, and full randomized trial on the left-hand side in here. And then across the top are the components that are very similar to the re-aim ones. They have to do with implementation fidelity and intervention fidelity, reach, adoption, sustainment, and the effect ultimately on the health outcome itself and what the potential use is. So all of these things you can just see that just in a simple form in here. Some of those with no new empirical evidence, you don't need very much information in here. Implementation fidelity may not even need to be measured if you don't need any new empirical evidence in here. But if you go down to the more serious ones of full randomized trial, you're going to need to do more. So I'm going to start back again with scaling up and say, what does this conceptual theory of mediation mean under scaling up? And remember, scaling up is going to this essentially the same conditions that we already had. In Cook's principle of proximal similarity, that is that there's a high correspondence between the original trial, which produced the evidence, and what is to. So it requires similarity of these components in here. If you have a scaling up, you don't need very much in the way of new evidence to show that you're going to be able to have some effect. You may either have no new evidence or maybe some proxy evidence associated with that. So instead of working with measuring fidelity, intervention fidelity directly, you might want to just get a clinician's self-assessment of their fidelity of delivering that program. That's a lot cheaper to use. You may not be able to need much more than that. So let's go to issues with scaling out and focus around HIV prevention in here. The principle of discriminant validity in here really says is that there's some measure out there that tells you whether or not you're going to have the same effect or not. So adherence is a good idea, an indicator in here. If you take PrEP pills routinely, that is high adherence in here, at least 70%, the relative risk of HIV infection compared to the control condition is very high. It's about a third of what it is with relative to the general setting in here. But if you have low adherence, less than 40% adherence to using PrEP on a daily basis, the relative risk is essentially one. It is the same risk as you'd have in the general population that's doing that. So adherence is a core piece in the modeling here, and you'd want to emphasize in your modeling scaling out. Here's a simplified sequential mediational model. This is something that we've used over time to try to identify it. It builds on David Chambers and colleagues' point about a delivery system that changes over time. So there's a clinical intervention, a delivery system, and a population in here. All of those interact with one another over time. And what we're looking at in here is these components that you can recognize as re-aim-like components: implementation fidelity, intervention fidelity, uptake of the intervention, proximal outcomes, and then distal outcomes. I've used Roman letters and Greek letters in here. You can measure these at different times in here. For example, the Roman letters represent the mean values of implementation fidelity, that's A, or intervention fidelity, that's B. Whereas if you look at the relationship between how well your implementation fidelity relates to intervention fidelity, that's alpha in here. And so those are relationships. In the implementation trials, you have that data. But that's a pretty costly one to do, and it's going to take a long time to try and do that. So the question is which of these do you really need to have? Sometimes just a few measures to give you these Roman letters will be sufficient to tell you whether you've been able to do enough or not. So let's go back to this example of borrowing strength for type 3 scaling out with a different population and different delivery system. And this is with young African Americans and not reachable through regular clinics. And consider this on-demand dosing. So what is that? There was a prospective ongoing on-demand PrEP trial that was done in France and Canada. It's an open label trial in here. And one of the things it said is that there's a huge drop in infections of HIV if you can get people to take PrEP at the times that they need it most. So it is prescribed on a daily basis, but that it's really emphasized that if you can take the correct use of PrEP, meaning one pill taken 24 hours before sex and one pill taken within 24 hours after sex, you can have a really strong impact on the results of this. So this means if you can get the adherence around those periods of time when there is sexual intercourse, you have a really good chance to have an impact. So here's what a picture looks like in here. And I've added in here levels associated with this one. A type 3 scale out really is far away from some of the information that you could get from the original study. So there are probably no cases where you'd have a level 0 design in here for components in here of minimal change. And you probably need to have some proxy or direct measures in here, as well as some full-scale information. So these are just bullet in here, and this is what it would look like. So I'm throwing away a lot of the information in here. You may only need to do this kind of study and proxy empirical evidence in here around implementation fidelity. Can you get the leadership to be supportive of the intervention, for example, and make sure that the staff feel like they have the self-efficacy to support that evidence-based intervention? And that may be all you need on that part of the trial associated with it. Intervention fidelity You may be able to use self-assessment fidelity associated with that. When you're looking at reach and exposure, you may need to look at and get some measures of medication adherence in here. Maybe that's a self-report measure. Maybe it's more detailed information that's available. And then you would also probably want to make measures in here, ultimately down at the bottom in here, where you're taking really careful look at the health outcome in here. That's the number of individuals or the frequency of individuals who get exposed to HIV. That's from an HIV test. That would be a relatively simple, straightforward to do. This is a lot easier to do this kind of a study than waiting and doing a substantial, big randomized trial associated with it. So I'm going to finish with this kind of summary in here. We've given one example in here. But even a partial understanding of the underlying mediational model, you can use scaling out studies to borrow strength from existing studies. It would accelerate the rates of implementation of effective interventions, and it probably is something that could be used across different countries and different locations as well. It also promotes health equities, which are essentially necessary for implementation science to be successful. And finally, in here, scaling out can reduce costs and burdens of implementing new practices. So last point I wanted to make in here, I wanted to invite everybody to join the Prevention Science and Methodology group. The price is right, it's free. You can go to this one if you want to just search for PSMG at Northwestern, you'll be able to get to this location in here. It does have weekly virtual grand rounds. And right now it's including systemic racism, implementation science, methodology, HIV, drug abuse, suicide, mental health, other areas like that. And we've had a lot of activities in here, and it's been seen in 70 countries with places in our archive. So that's my points, and I wanted to turn this back over to Susan.
Thank you, Hendricks. Lots of food for thought. I think I just reminisce when Zilly and I were doing some work to develop some of the systems, the approaches to community systems approaches, where you reach out, you have to look at all elements in the community, and it's such a big amount of things that you have to bring under the umbrella if you're going to implement, that in your presentation, I can see that it can be, and not whittled down, but more targeted and more, it seems more able in any case. I was going to ask Maria to look at some of our chats. I'm sure we have some questions. I saw them flash over my screen. Maria, are you there?
Yes, I'm here.
Great.
Yes, Donna Mills, she asked before earlier in the presentation if were these evidence-based interventions implemented in urban or rural settings, or both?
Good question in here. This particular one, most of the studies in the United States around HIV prevention have been done in urban settings. It's also in the United States, there's a lot of HIV that's being transmitted in the South. There's less studies generally that have been worked on in there, and it's fewer individuals in the rural areas. It's one of the challenges of trying to get and deliver programs with enough evidence base about looking at rural effects in here. What we found in the trial that we did in California was that California and Ohio that I mentioned in here, this randomized implementation trial, was that it was more difficult to get smaller rural counties to deliver that evidence-based program than it was in other settings. And that's common in here. NIDA did have a really nice meeting years ago around rural versus urban interventions and whether they were, how effective they were. And we had a publication that came around there. Maybe we can send that around if people would like to see that. If there's follow-ups, I'm happy to have this as a discussion rather than just a, question and answer.
Thank you. Then there we have another question from Mr. Victor Norfleet, but we can address that in a different setting, as he's looking for evidence-based practices on intervention and prevention for after-school programming for city schools, kids, 5th and 6th graders, as well as middle schools, and he has his email there, so we can just address that question in another space. Thank you very much. So those are the questions that we have. Susan, you can continue.
Well, I think we just received
There's one more.
Just one more. Yes, sorry. Arthur Correa, great presentation, Dr. Brown. Would you have any specific consideration for scaling out US developed programs in international contexts?
I think that there are good examples of this already that have been done. The communities that care is a good model. I think that has been done internationally in England and in Australia and other places. That David Hawkins and Rico Catalano developed an infrastructure for helping communities identify evidence-based programs and prevention that would work in their own settings. And so that's one kind of a model of an intervention. It is really a community collaborative model. The community is in charge. The community is trained in how to deliver some principles around prevention to start off with, and then also to collect their own data about what their resources are and use that. It's interesting that in the United States, the community development team model, or the communities that care model was tested not in urban settings first, but in rural settings and in suburban settings. So it's just sort of the opposite of what the earlier question was about. And that was a good randomized trial. It did demonstrate that there was major reductions in substance use and violence as kids grew up with delivering programs in there. And only recently has that program being applied in urban settings. We have one going on in Chicago that I co-direct with Deb Gorman-Smith at the University of Chicago. And there's reasons for that. One of the reasons is that unlike community settings where there's rural or suburban settings where there could be one community collaborative that works in there, in urban settings there may be 20, and they fight with each other. They try to get their own resources, and it's hard to get all of those people together on the same team to try and work in there and have the links that are necessary with the mayor's office and other places like that.
I was just thinking, oh, sorry, Zilly, go ahead.
No, I was just going to have two comments I wanted to add to that. One is that I think that social capital is a big issue and a big challenge for developing community coalitions, and sometimes it's easier to do that in rural and suburban areas than it is in the inner city. There are, as you're finding out in Chicago, competition. The other thing I wanted to just bring to your attention, and to me is a real challenge, is that we have replications of evidence-based programs in different communities around the world, and we're getting different outcomes. And when I've talked to some of the people who have been doing those studies, I found that implementation varies. And I really wish that our scientific community, Hendricks, would get a group together to talk about what the differences are, why we're getting different outcomes, because I think this could be very challenging for us to talk about evidence-based programs when we have some people who aren't implementing it the way they were originally designed. The other thing I wanted to talk about is that you talk about systems, delivery systems, and for prevention, certainly in the United States, we don't have a delivery system for prevention. It's very spotty. I wouldn't call it a system. So that's something else that I think is another challenge for us in the prevention field. I'm sorry, Susan, you can go ahead.
Oh no, I just was going to what caught my eye in terms of your methodology group, Hendricks, is the question of systemic racism, and sort of looking at, as you looked at the inequities in terms of the nature of a problem, which over affects certain groups, and yet you've got this. You have this whole big problem, but sort of targeting it in on these. I mean, is that how your group is beginning to think about stuff, instead of saying, okay, we've got these people who are underserved and it's prevention, and this may have worked in Oshkosh, but how can we target down? And you also, the thing that struck me was you're talking about the outcomes. We're so long looking at mediating factors and so many things in the pipeline, but in a way you're targeting the outcomes, you're targeting the populations at risk, and then how can the implementation process be? I don't know, I'm just thinking that it's beginning to get to be an important way of looking at it. And an important way of developing research on it to make sure that you're capturing what has to be captured in the intervention in order to make a difference. And I think we all work in that concept of making a difference. And I think practitioners do that and want to get there. And I think that it's encouraging to think of this scaling out that way, that recognizing what the outcomes are and working backwards in a way.
Yeah, and I think both Susan, you and Zilly are really pointing to, what are the things that are needed at a system level to be able to deliver these kind of programs. I did want to mention an example. I think this is a really wonderful example of work that Marian Forgatch at Oregon Social Learning Center did, delivering a parenting intervention. And she got a call one day from colleagues, from people in Norway. And Norway wanted to deliver the take her intervention and adapt it to their systems and implement it nationwide. Ironic, because they were successful in doing that. And in the United States, Marian's intervention was only in 2 states, I think, but not in other places in here. One of the key factors was that they had a real commitment from the entire health system in Norway to do that. So the first person who got trained in it was the equivalent of the Health and Human Services Secretary in Norway. And a second piece that they did was they took her manuals and translated them. By the time it was translated into Norwegian, they owned it. I think that's a fundamental piece of how do you try to make programs work in other settings in here. If you don't have the community and the government behind it, it's really difficult. There's a colleague that, and getting back to this issue of disparities, we we really have a limited number of research studies that are going on with Latinos in the United States in prevention. One of my sets of good colleagues at the University of Miami, that Willie Prado is directing in here, has taken a program called Familias Unidas and done about 7 randomized trials in the United States. But also, he and his colleagues have worked with Chile, and Chile has adopted Familias Unidas to be used in all of its counties in their entire country, and has a 5-year plan to do that and to support that. So I think that there are really good ways and good models to try to take some of these programs to scale that look like they're really promising. I wish we'd done the same thing about some of the programs that have been developed in Latin America and toyed around with them in the United States, but not adopted them.
Yeah, yeah.
We have a comment on the chat. April Schweinhardt asks, Zilli mentioned that different communities are implementing differently. How do you account for place-based and contextual modifications? Zilli or Dr. Brown?
Yeah, it's certainly challenging. You know, I think in the prevention field, I think with NIDA's help, as well as some with NIMH, the role of the community has been really strategic. I think the first step you do is work closely and build a partnership with the community coalitions that have powerful relationships with the government and with the people that they represent, the key stakeholders that are identified there. We're doing studies right now on reducing overdose deaths in different counties in the United States. And it's very clear that the exact relationship in here, the causes of mortality from overdoses is hugely different depending upon where you are. Some places have enormous amounts of disparities, and others are less so around the country. Rates are hugely different. The drugs are different, et cetera else. But the first step we do is we work with the community and identify from what they say they need to do. And I think work within that, we sort of call it working under the aegis of the community in order to do that. Zilli.
Yeah, that's very
useful things to say.
No, that's really important, Hendricks. Hendricks, I think that you hit the nail right on the head. I mean, I think that we have to work with the communities, with the community context. And just a reminder for the group that next month on September 9th, we're going to, Filippo Castro is going to be our prevention talk on fidelity versus adaptation. And he will talk about how to work with communities to be able to adapt the program, but also to maintain fidelity. So I think it was a nice segue question for our next prevention talk. But my concern was on the outcome measures that people were getting in the different countries. And for instance, I won't mention the country, but they did Strengthening Family 10 to 14, and they got different outcomes. They didn't get as strong outcomes as we have in the United States and in other countries. And when I talked to the investigators, they actually targeted older kids. They were older than 14. So even they didn't adhere to the age of the population, so they didn't get the same outcomes. And for me, that was like a duh kind of thing to do. So I think we really need to dig deeper into why these different why different studies are getting different outcomes. I think we okay. April. Yeah, we're going to be posting that on our APSI website soon. Maria will be posting that. Be able to see when get more information about Felipe's talk. As I said, it'll be September 9th.
Yes, that's the date. And tomorrow we will have the information online. So if you sign up to our website, you will be receiving the invitation right to your inbox.
Well, I think thank yous are in order. Zilly, do you want to close us out here?
I think this was a really very, very important presentation. Thank you so much, Hendricks. For me, it raises a lot of interesting questions. I'm trying to address how do we develop delivery systems so we can implement prevention programming, and it is a challenge, I think, for all of us, just even to keep it within the prevention area and not going beyond. For instance, it'd be nice to integrate many of our prevention programs into other kinds of systems like a healthcare system. So I want to thank you very much, Hendricks. I suspect there are going to be more questions. People will be following up. If people have questions, they can put them on our website. We'll be happy to transfer them to Dr. Brown, or you can address him directly. Thank you very much, and we're looking forward to seeing all of you next month.
Bye all.
Thank you, Hendricks. Take care.
Thank you very much too.
Bye.
Good to meet everybody.
Hi, Hanno.
Hi there.